So my name's Donnally. I practice in Dallas, Texas, and today I'll pretty much talk about the difference between robotic navigation and kind of the traditional, what I call old school basic navigation. And I like to always kind of say, just like you, I'm a minimally invasive and complex spine surgeon, because I feel like, aren't we all? Like, I've never met a spine surgeon who says, oh, I'm not a complex spine surgeon, I'm not a minimally invasive surgeon. So I kind of think it's funny when you see on like people's LinkedIn profiles, they're like, oh, I'm a minimally invasive surgeon. It's like, congrats. So are all we. So I try to have fun with that terminology. But in terms of what I'm going to talk about today, robotics initially was really just an extension of image guidance. It was just an extension of where to put your instruments, and that was great. And that's what it was the last 5 years, and things were good, things are great. But as we've definitely seen today from some of the other really good lecturers, over the next 5 years, here's what's going to be coming down the pipeline: lumbar decompressions. There's no reason we can't kind of sync that with something like the Masonic bone scalpel and have a safe way to, and if anyone steals that idea, that's mine, kind of steals that and does that. Targeting endoscopic portals, that's already something that I think another lecture after mine's going to be talking about that, but that's a thing. Cervical fusions, the talk before mine did that. Telesurgery, so this would be kind of like the famous appendix surgeries back in the day where the surgeon was in New York and they were doing the surgery in London. So there's a way that this could be done in the future. Rod bending, real-time intraoperative neuromonitoring, and even disc arthroplasty, something that we haven't really mentioned at all today, but how can we use the robot to do motion sparing? The biggest disadvantage of the robot right now is if you're using a robot, you're fusing a patient, and that kind of sucks, right? Like us as spine surgeons, we're trying to think of ways to get away from fusions, so why not use this robotic technology to promote the non-fusion stuff? So just in short, I'm not as famous as some of the other doctors here. So my background, just in terms of who I am, my residency was at the University of Miami. We have a lot of sports coverage, team coverage, a lot of beautiful views in Miami. So if you're going to pick a residency program, pick a place where you have beautiful views. I did my spine surgery fellowship at Rothman with this guy named Dr. Vaccaro, Kepler, Hillebrand. We did a lot of robotic technology there. We were a very Globus-heavy institution just because their headquarters is about 20 minutes down the street. Traded my beautiful views in Miami for nice, chilly, snowy views in Philly. And then now I'm in Texas, specifically in the Dallas area at Texas Spine Consultants. And my views now are my family and my 2 kiddos. So in terms of robotics, when is robot navigation better than what I'm kind of jokingly saying is the first generation old school nav, kind of just the O-arm spin and guided tools? So in general, I kind of break it down into a couple different categories. So freehand nav really just takes these still images and it just gives you a picture in time of where your instrument is, whereas the robot, it really can place all these screws, as we've mentioned earlier today, hours, days, even weeks before your surgery. So that's a huge advantage, is you can plan the entire construct. And we've seen some great examples today. I'm going to give a great example today, whereas if it was just the traditional OR nav, you can't really plan your whole thing. You're doing that right there in the OR, whereas if you're doing this with a robot, it gives you the advantage of kind of planning this and having the whole thing. So I'm stealing a video from Dr. Hod at USC. It's a great video, and I thought it was one, instead of making my own, I would just steal his. The best form of flattery is imitation. But this is going to be a case example that he shows, and I've muted the audio just because he speaks better than me. I can't have you guys hear how much better he's doing it in describing this, but really shows kind of in some of the other videos where the osteotomies will be, where the robotic arm will take you to kind of get to that point to make everything look better post-operatively. That's the whole goal. So by doing these pre-op spins, planning the screws, that's what the robot can do that freehand nav is not allowing you to do. He'll give another example where he's able to go in, and while that doesn't look as minimally invasive, it was the same thing Andrew was talking about earlier, where it's just cutting through the fascia and little strips. You still have your midline incision, but by doing that, it limits the amount of tissue disruption. That's just a whole nice goal. Here's another third case he shows of huge deformity. If you just do the O-arm spin and plan this in the OR, that's a lot of brain power. That's a lot of work. That's a lot of kind of thinking on the fly. Whereas if you do this robot, look how crazy that looks. But if you're using the robot, that makes it quite simple. The expression he uses is it's a forest of towers. You can't see through that if you're using fluoro. There's no way using non-image navigation you can see through that, but this is how they did it. I control all their towers.
I just have to make a comment. These are actually my slides that he's using.
Oh, there we go.
I just, in case you have questions for Dr. Ha, you can just ask me because I can answer you about.
See, that's actually
those are my gloves right there because out of
you did a great. So. I'll tell him that you did a great job. It looks very nice. So it just echoes the exact thing we were talking about earlier. I know Martin, obviously, but look at that. How do you see through that? And that's why I kept hammering you all day today. It's like, how do you see through all those towers? And this is the exact way how you see through those towers is you use the robot and you plan through, and that's how you're able to do your interbody fixation. So another way in terms of when the robot is better, in my opinion, compared to freehand nav, is doing this new hot surgery of single position laterals. And I say new, been around maybe for 10 years as we established, but it's kind of coming back in favor. But one of the reasons it's maybe coming back in favor is the robot makes this somewhat pretty challenging surgery less hard. From a stance of where you're standing, it's easy. You can sit down. We feel like hand surgeons now. It's great. We finally have an excuse to sit down in surgery, and these are these single position laterals where the robot tells you exactly where to go, whereas if you're doing the old school freehand nav, it's not that easy. Another way that the robot technology, in terms of its navigation versus the other navigation, is better is just the strength of it. If you're using the freehand nav, you're kind of blind. You don't exactly know where you are when that screw is going down. If the patient's very big, and in general, many patients are very big, you can push through that tissue and it might put you off some. You don't really have anything stopping you except for your own muscle memory and strength. Whereas for robotic technology, that's a strong arm. You can hold up to 180 pounds. So you can do pull-ups on there, Martin, if you wanted to, just work out during the case. Okay, another reason that I would like to argue that the robotic navigation is better than the nav, again, is you can purposely leave screws proud. And again, you plan this ahead of time. So if you have a spondy and you didn't correct all that from your inner body, or your plan for whatever reason is not to use an inner body, or just or if you want to lock it into one place and then pull that back, well, that's what the robot can do that nav can't. You can purposely leave a screw proud. You can leave the L5 more proud, final tighten lock on that, and then pull that L4 back when you start reducing there. And that's just a nice, unique advantage you can try to do with the old school freehand nav, but the robotic nav really allows you to do that much more efficiently. So here's one of the things where this slide is going to be outdated in even a year or two from now. So one of the other major differences is the expense of the two. So both systems, essentially you need a CT scan, and that's changing even as we speak. Now you can maybe, on some systems, use a pre-op MRI. You can use these 3D C-arms. So even the concept of needing a CT is not even 100% accurate, even as I speak this now. But that's one thing that both freehand nav and robot need. The obvious difference is the expense of the robot. If you're using the freehand nav, yeah, you have the O-arm, but again, I've now said that those are equal in both. But the robots are expensive. They can be up to $1.2 million. But there's many models in terms of how hospitals can finance this or even lease it. But my argument in that picture below is that, look, robots are somewhat new technology. Just like a TV you bought a couple years ago, those prices come down when other competitors come out, when we find new ways to do it. So yes, robots are expensive, and I agree that we don't want to be spending too much money on technology that we can maybe not have to have. But that price is going to come down. The more people using the robot technology, the more robot technology that'll come out. And there's just cheaper ways to do it than the traditional $1.2 million robots. So now I'm going to kind of, this is a paper that kind of even argued it was, I try to, in the papers I'm going to talk about today, I try to use newer papers from respected journals. I'll just kind of say it like that. And this is one that just kind of did a breakdown of looking at their case, almost 2,000 cases, and just the cost savings of using the robot versus not using the robot. It's a little more, they estimate a little more than $1 million a year using the robot technology, and that's in terms of not converting cases to open. That's in terms of making sure things were all in line and not having to go back. So there'll be a couple other things I'm going to go over, 4 kind of key concepts in terms of robots and kind of answer these questions about the myths of robots for those that, right now, this is legitimately me preaching to the choir. Everyone in here likes the robots, so no one's going to disagree with those. But for those that watch this on Seattle Spine Foundation's YouTube platform later, who maybe aren't believers in robots, this is more guided to y'all. So the first thing you think, robot spine surgery takes longer. Well, okay, let's talk about that. Pretty good journal here, Spine, pretty new, 2022, and they had a very good review. They looked at doing minimally invasive T-lifts with just nav versus robot, and they found there's no significant difference in the total time versus the OR time. So I'm not 100% arguing robots faster, but in one level MIS T-lifts, they were the same in terms of the speed, but the advantage of the robot, less radiation. So that was nice. Here's another study, World Neurosurgery, 2021, same thing, where they looked at one randomized study, 5 other studies, and it was the same argument. When they compared CT nav versus robotic nav, They are the same for OR time, same for complications, same for revisions. So the robot thing is definitely not taking you longer. The next concept, robots are hard to use, so I don't want to use them. Well, that's just not true. We've already talked about it a couple times earlier today in terms of learning curves. There's multiple studies out there that show what the learning curve is, and in general, these all kind of focus on the same argument that the learning curve is probably about 20 cases or 6 months, just depending on how many cases you're doing. 20 to 30 cases, what multiple studies looking at the robot in terms of when you start to be proficient and safe. The next thing is the accuracy isn't any better with freehand nav. Well, let's talk about that. Here's another study. This looked at it compared about 500 patients, and what they found is robotic navigation was almost 6 times less likely to have a surgical complication, less likely to have a revision, and again, the surgical time was the same. So that's great. And most importantly, radiation was better. You know, we have such a better understanding of radiation now than we did even 10 or 15 years ago where we weren't using lead. Now I think we all very, very sadly have some of our mentors who've had leukemia or lymphoma. And so radiation's like a big deal now. Back in the day, we didn't really care as much because it was cool not to wear lead, or you didn't think about the long-term things, but avoiding radiation is kind of the key thing that we don't talk about enough in terms of this robotic and even navigation technology. Another screw, not to get off on that tangent, sorry, another paper, not to get off on that tangent, talked about the accuracy of these, and it looked at, again, randomized studies, comparative studies, and again, it indicated that the screw placement was indeed better with the robotic guidance compared to the freehand nav. Okay, so here's another thing that I think I add a unique aspect on in terms of what I can personally talk about. So my patients don't care if I'm a robotic spine surgeon. Like, do they even know? Does it matter? You know, at the end of the day, our patients who we're taking care of are clients. You know, we have a business to build. They don't just, unless you're at, you know, Mayo or Keck or you're Martin, they're not just coming to you just because of the institution you're with. Part of it is there's a marketing aspect to what we do. Like, we are selling a product, and it's safety, accuracy, and reliability. But one of the things I think that the robotic technology does, if you think about, you know, for the ortho people in the room, we all know about joint replacements with a hip and a knee. And I think if you're ortho trained, you know that the studies are about the same for getting a knee replacement with the robot versus getting a hip replacement with the robot. But I kind of want the robot. It sounds great, right? Like, even if I know the studies, I'm like, I want a robotic knee replacement just because that sounds more fancy. It's kind of the same thing in spine surgery. If you are comparing spine surgeons, if someone's using a robot, that implies they're doing technology. It implies they're advanced. It implies less pain. It implies faster rehab because robots sound cool. So I think that's one of the key things to robotic technology. You know, in terms of marketing yourself to your peers, these are friends that you grew up with and treating their parents. From my standpoint, this is your OR staff, hospital administrators, therapists. I'm not directly saying you're targeting patients. It's more so that the other medical community you work with, if you're telling them that this is what you're doing, I think that's an important aspect that people really should focus on in terms of another unique advantage that we don't really talk about with robotic technology. Another thing is, let's just look at kind of one of our publications that most of us check every day or every other day. It's Becker's. Every time you get on Becker's, they're talking about robotic technology. This is what drives the market, is what Becker's is telling us it's cool, and this is what we see all the time. Every story on Becker's these days is talking about it. One of my good buddies, Dr. Galizzi, he's kind of pushing the envelope, and he's doing kind of new, cool things. And if Becker's highlights him, you know, he's not really at he's not at the Rothman Institute. He's not getting podium talks, but because Becker's highlights the new things he's pushing with robotic technology, he becomes a household name in terms of spine surgery. And that's just a great way to kind of use this. It's a way to promote yourself to your peers using this newer technology. And that's kind of a key thing. So in terms of another unique marketing aspect of it, is the social media marketing aspect of it. That's one thing that they wanted me to talk to you about today. So in terms of using your social media, you know, you're not posting pictures of your kids or food or something like that. It's a way to show your patients. It's a way to show your family and friends kind of what you're doing. And this is what Dr. Galizzi does. He has, you know, going through his posts, some of them are him skiing in Aspen because he's in Vail now. But in general, a lot of his stuff is just robotic technology. You can use different clips of you just doing things. This is just me telling the world I'm in charge of the robot spine surgery department at Baylor Frisco, and just cutting that with images in the back. But this is what my patients see. It's kind of a self-fulfilling prophecy where maybe this doesn't bring them to me, but once they're referred to me and they see this on my social media platforms, they're like, oh, that guy uses robotic technology. It kind of validates. It helps maybe avoid them getting a second opinion because they subsequently go to your stuff after they've met you and they feel more comfortable with you. So I think that's a unique aspect of the robotic technology. In terms of where we're going, there's no doubt, just looking at kind of the PubMed searches of robotic spine surgery, where are we going with it? If you just were to Google robotic spine surgery, robotic spine surgery safety, each year, more publications on these topics. This is a hot topic. This is what people want to publish. This is what people want to read. But to kind of summarize it down, I think there's really the dirty truth about robots that we don't talk about enough. And I think this is kind of where they have some of their main advantages. Is the accuracy better? Look, at worst, it's the same accuracy. And that's not bad. Navigation has good accuracy. I'm not saying that's a bad thing, but at worst, it's the same. But there's much less surgeon fatigue. And that's kind of what we talked about earlier today. How come in some of these studies, they say they're 99.9% accurate, but in real life, we all know we've had breaches, and where does that come into play? Surgeon fatigue is a real thing. If you're just doing one case that day, you're maybe not going to get as fatigued, but this is something where if you're doing 4 or 5 cases a day, you're using the robot doesn't get tired. It doesn't think about taxes. It doesn't think about traffic or what you're doing for dinner. It just does its job. The robot does not tire out. So I like to say it keeps the average surgeon safe. It doesn't allow them to get distracted and has them kind of just do the thing they need to do. In terms of, are the images better? Are your x-rays better? Are your outcomes better? Well, I would say yes. By doing the robot as opposed to traditional lav, it forces you to stop before the surgery and plan your screws. It has you think about the anatomy. It has you really look at those facets to plan those screws. And that's kind of the key thing in terms of planning each of your screws and knowing the case you're doing. So that'll kind of open up to questions. Kind of the key things I emphasize about the robots is, what is your goal with the robot? Are you trying to go faster? Are you trying to be safer? Are you trying to make the surgery easier? In the beginning, you should start slow. Staffing is going to be the huge bottleneck. The OR staff that you're working with, they're not going to know exactly how to do it. You just have to be patient and work through it. A key thing is to support your peers. If they put up a case on social media platforms, encourage them, ask questions, kind of tell them how great everyone else is doing, and then see, does this make you busier? Does this make you faster? You need to find kind of what your goals are with the robotic spine surgery in terms of why you're adding this extra cost to the healthcare system, but how you can justify it with your outcomes. With that, I'll take any questions. Perfect.
Actually, Chet, I have one question. In terms of, I'd love to hear a talk one day on how you put together all these videos. I stare at them and try to figure it out, and I literally am still using Windows Movie Maker, which was probably made in the 1980. That comes bundled with an older version of Windows. But yeah, how do you find patients mention this, or they come and they tell you beforehand or afterwards when they see that you're leveraging these technologies? Essentially, I'm sure they make the leap that it's for their safety, it's for their betterment of their outcome and so on.
Yeah, I think it's kind of a two-way street. Initially when I was doing some of the digital marketing, as I said, I never was targeting patients. It was more so, I grew up doing social media, so just kind of was something I did. And it's more so to promote myself to the other. I'm not joining Rothman Institute, unfortunately, so I'm never going to be having a huge research podium presentation, but in a way it doesn't matter. If you can put something out there on LinkedIn or Instagram or Facebook, that's what your peers are seeing more than the one conference they may go to a day. In terms of the patients, that thing kind of just happened naturally, where it wasn't necessarily that brought them to me, but once they found me, then maybe, you always Google your doctor. If someone's like, oh, you should go see Chet Donnally, they're going to Google me to find my place, like where I practice, and then they might go to my own website, and then they'll be like, oh, this is actually a lot of information here, and it's not a generic HCA-generated website that just says, this doctor's passions are helping patients. Like, cool. It actually has videos to YouTube, and it helps them get to know you better, and they're like, oh, I actually got to see, he has a family, so he has some ethics. He has people that like him. So it's kind of just a way to develop your relationship with the patient, and that's something that's kind of helped me grow my practice extremely fast early on.
I think that's a great point too, and I also echo that. I'm not. I'm not as famous as Pat Johnson, right? And so when people go and see Pat, they already know who they're seeing. And I remember thinking that, when I started, you Google your doctor. I would Google all my doctors.
For sure.
And I think the idea in having something out there to show that you're a real person, right? Yes. That I think most patients assume that their doctors are going to be, but there's so many scary stories, right? Dr. Death, all these people. And you just want to be able to see, hopefully, that your doctor's just a real guy, real person who cares about you and people and, things like that.
Definitely.
Chet, that was a great talk, and I have a question for you, and also Martin, and maybe kind of anybody, is that what data is there about your topic here? I have my own views and opinions. In fact, I was going to show a case of which the robot wasn't working. Actually, my last case that I did this week, and I did it with navigation, and we had a problem. It had a pedicle misplaced, and so in my experience, the robotics actually, and I don't have the data though, is we collect a lot of data about efficiency in the operating room and things like that, but we don't really have data about it. But my gut feeling is that the navigation is, as you said, it's the step to robotics, and the robotics, at least at this point, I think is better. It certainly is in our experience. I mean, I just looked back and said, how many cases have we had a problem that we had to do something else and have another surgery or something? I mean, it's measured like a year ago. I mean, 10 years ago, we used to have patients once a month, there'd be something was a little tweak of an issue, and it's almost never now. And having the robot break down this past week was a problem, and it created a problem. And so that's my data. Okay, you're only as good as your last case, and that was my navigator case, and there was an issue.
Exactly. Well, we've had a lot of good institutions out there, of a lot of patients, and the good news is there's a lot more of the 3 big robots, so it's able to kind of standardize that information. It's not just one robot system's better than others. It kind of says no matter which robot you use, you have better efficiency, accuracy, and safety. That's kind of the 3 keywords that I always try to focus on.
Yeah.
Okay, thank you.
Okay. Thanks so much.